meets the needs of our patients. And the first is a factual, a basis of understanding the laws and what they really say and what they mean and what they don't mean. And that's really critically important because there's a lot of disagreement over that. And I think both Lyman and I have heard Lucia talk before, and she really is an expert at kind of helping tease that out and get rid of some myths and around that area. But the second one, she can't help us with, and that's the leadership to kind of have the courage to make the changes necessary to actually do what's needed. And so, because it's easier to sometimes to say, well, we're not sure, so we just won't exchange any information. And it takes some courage, but we have to have that courage. And if there's individuals in our organizations who are pushing back against it, it's sometimes you might feel like giving up. But you just encourage you all to think about that role as leaders in our organizations. To if we have the facts at our disposal, to have the courage to really use that to make the health information exchange work. So before I turn over to Lyman, the other thing I just very briefly apologize to the folks here in the room. I'm going to have to step out. We have our Department of Healthcare Services audit, which is having its exit interview starting right about now. So I'm going to run over there, hear what they have to say, and then I'll be coming back in. So just apologize. I would not normally have to do that, but it is our auditor. And so, very much so. So without further ado, let me introduce the Director of Connect Healthcare, Lyman Dennis.
Thank you all. This is a very exciting day for me and very exciting hour. We're fortunate to have with us as a speaker Lucia Savage, she's now the Chief Privacy and Regulatory Officer for Omada Health, and I asked her to say a few words about what Omada Health is. She was formerly the Chief Privacy Officer for the Office of the National Coordinator of Health Information Technology, and when I'm sure many of you have heard Karen DeSalvo speak or seen her. She's a wonderful, bright lady that was the secretary in a prior administration, and she introduced Lucia, saying that in her previous role, Lucia's been working on the complex issues of maintaining patient privacy while working to fully realize the potential of health information exchange for better care. There are a lot of folks that talk about privacy and security and say, well, you have to talk to your counsel to do this, and very cautious and not really helpful. But Lucia's completely focused on the practicalities of making it possible to exchange data in a legal and professional way. So she was also the Senior Associate General Counsel for United Healthcare, the General Counsel for Pacific Business Group on Health, and a lot of you who know Pacific Business Group on Health know what a great organization that is. She was a Benefits Compliance Officer for Stanford University. She has her JD from New York University School of Law. She has a bachelor's from Mills College in History with honors and a Phi Beta Kappa. The thing I would say in a summary is that Lucia's focus is on letting us figure out how to exchange behavioral health information legally and prudently and securely. And I think she's a perfect speaker for us. So I'm really excited that she's here. So thank you very much, Lucia.
See, he's a little taller than I am. Okay, I'm going to do a sound check too. It sounds like the mic is working. Thumbs up from the remotes. I normally like to start with a little bit of hand raising. So all of you in the rest of Northern California, and I've been to almost every location where you are. I'm a Northern Californian. I live in Oakland, and I'm happy to be back from DC, where it was 17 degrees this morning. But just a couple of questions. So how many of you are sort of medical professionals, nurses, physicians, physician's assistants, any a couple doctors in the room, any lawyers in the room? One lawyer. Any IT people, InfoSec, a few InfoSec, quality management? All right, data scientists or burgeoning data scientists. All right, that leaves everybody else. So I wanted to give just a couple of caveats. In the deck, which I asked to be distributed in its native PowerPoint form, are a lot of hyperlinks. And probably 80 to 90% of the links in there are official government documents. And so the first thing I wanted to tell you is there is a wealth of resources that the federal government produces on this issue, but you have to go look. And for those of you that are in what the bleeding edge of trying to convince a cautious person what to do. Many of the resources I'm going to go over today, we created specifically during my time at ONC so that you could take them. They would have government seals and government office approvals on them. They wouldn't just be some random white paper you printed off of Wikipedia. And you could take them to your lawyer and say, well, the agency that's in charge of regulating this says it means this. And we really encourage you to do that. I'm going to walk you through a fair amount of those resources today, but I provided links because in the native form, because I wanted the links to work. I'm not very good at translating from PowerPoint to Adobe and making the links still work. And I wanted you to be able to take it back to your offices and use those links. That being said, I'm not giving any organization or any person legal advice today, although I am a licensed California attorney. And what I'm going to tell you today is based on my own experience and my own expertise. And unless I'm talking about Omada specifically, it's not really the opinion of Omada. So Lyman did next slide, please. All right, so this is a little summary of me. I want to tell you a little bit about Omada. So Omada was founded in 2011, right at the beginning of the sort of high-tech, what we now think of as the high-tech infusion. If you remember, high-tech was part of a stimulus package, and billions and billions of dollars went into the healthcare industry, mostly in electronic health records, but it in fact did what it was supposed to do, which was jump-started a whole new part of the healthcare sector. We supply digitally enabled behavioral intervention counseling to people that's focused on metabolic disease. If you are in CalPERS through Kaiser, Western Health Advantage, or HealthNet, you have access to this benefit. If you're in the UC system, through Kaiser, HealthNet, you have access to this benefit. And we have many other health plan customers. In fact, Sutter covers this for its employees. We just did a deal with Sutter. So we're the largest DPP in the country. We've served 140,000 people since our inception in 2011. And if you don't know much about diabetes prevention programs, you can read about it a little bit on our website. But I'll tell you two things about Omada that were really attractors for me in choosing Omada. And I had a lot of options when I left the government. One is I am all in on value-based purchasing. I have been since I worked at PBGH. I have personally witnessed firsthand the financial churn that happens in a fee-for-service environment if you're not a well-informed patient and you don't really know about the care that's happening. And Omada only gets paid when you take your lessons and when you lose your weight. If we fail, we don't get paid. And that was very attractive to me. The other thing that was really attractive to me was the idea that it's this amazing combination in our ecosystem. Of course, I'm a fan. I work there, of digitally enabled communication that helps people talk to each other. So I'm just going to sideline me for just a minute while I tell a brief story. In our world, we ask our participants to log their food. And our real-time data science program sends signals to our data scientists, which we can then turn around and give to our coaches. So we had a participant a few years ago who was logging a protein shake at 3:30 every morning. Day 3, we decided this was a little bit unusual. They flagged it for the coach. The coach securely messaged on our platform the participant personally and said, hey, what's going on at 3:30 in the morning that you're getting up to eat a protein shake? Because protein shakes are okay on an interim basis, but you don't eat them all the time. And it turned out that person had a new shift. They were on the swing shift. They had to be at work at 4 o'clock in the morning. And the coach took that as an opportunity to talk about what were, real food, high nutrition, grab and go, not protein shakes that you could cook ahead, have in the refrigerator, and grab on your way out the door, whether it's hard-boiled eggs or make a sandwich the night before or whatever. So it's a really interesting combination of the data science signaling to us that something's going on and taking that signal and turning it into a provider-patient interaction. And I know that that is part of the holy grail of electronic health records. Omada's data is a lot more simple than what is in the everyday hospital electronic health record or ambulatory setting electronic health record. I know that, but I also know the data scientists are on it and they're going to figure it out. So next slide, please. So what are we going to cover today? It's a fair amount. I'm timing it for, there we go. I'm timing to do this for about 40 minutes and leave room for questions, and I'm planning on you guys all figuring out how to make sure that people remotely get their questions answered. So the first thing we're going to talk about is what do we do when a person wants their own PHI? Why do we say no? And we're going to do a little bit of imagining about what the world would look like if we actually more freely gave people their own data, and why is that required and when. We're going to talk about The way HIPAA allows us to share, there are about 15 exceptions besides that one about an individual. We're going to go through this in a fair amount of detail using these materials that we created in the government. We're going to talk about how those relate to California Civil Code 5610. And I have battle scars from Privacy and Security Advisory Board in 2007, so I know exactly what we have gone through on this in California, but I didn't want to leave today without addressing that. We're going to talk about the difference between mental health data and data regulated by 42 CFR Part 2, which is a huge area of confusion even for Congress. We're going to talk a little bit about security. I know we have one or two InfoSec people in the room. I'm not a security professional. I'm going to give some names to linemen for another lunch conversation for you guys. And we're going to talk a little bit about what's coming down the pike technologically because of 21st century cures and some of my favorite use cases for health IT. Next slide, please. So the first thing I want to cover is that we are actually required to give PHI to people. Straight up. There's no limits on this. The only limit is if you're a prison medical system. Do I have any prison medical systems here? Or you're a psychiatrist or psychotherapeutic professional, and it's your notes. Mind you, that's notes. That's not the claims data. That's the notes you take during the therapeutic session. Those are the only exceptions. And we have some time limits in which we have to supply this. I won't give it the details. The link supplies a lot of the details, but I want to talk a little bit about how this works in our modern era. So this is an old rule. This rule dates back to the very first HIPAA regulation, the Christmas regulation, December 2000, and it's only been expanded. It has never been constrained. And it actually is a fundamental element of the Fair Information Practices. So for the people old enough in the room to know what those are, go back to 1978. And if you're following Europe at all, you'll know that the right to access your own data is now a fundamental part of the European protection regime based on the Fair Information Practices and in fact modeled in no small measure on HIPAA. So fast forward to high tech, and in the high tech law, in the statute that Congress passed, they amended the regulation via law. And the new amended regulation says that an individual has to be able to view, download, or transmit their own data from their physician's electronic health record. And it's right in the law. And so what we did with that at ONC, and this started way before my time, was we went through a process as we wrote those prescriptive software rules of trying to write software rules that would cause this to happen. And CMS, if you remember the rubric for meaningful use, then created behavior rules that you had to use the software in a certain way to get the incentive payment. And so there were, in the second round of meaningful use rules and the second software rule, there were specific purposes for this view, download, transmit. Now, we know, in fact, retrospectively, that very few people took advantage of it. We've done some studies. We know that it's really hard to find the transmit button. It's not necessarily native on a mobile app. Let me just how many of you guys actually have a portal account on your phone and you message your doctor or get a new prescription from it? Not too many people. So sometimes the cobbler's daughter has no shoes, and that's the world we live in. I would urge you to try it. If you're in this space and you're interested in this, you should do it just to test the functionality. My husband has an iPhone. I'm an Android user. We're having this wild debate right now about Apple and its new forays into individual health information because he has all these capabilities, but I have the cheap phone. So that has been there for a while, view, download, and transmit. But you'll remember in 2015 at HIMSS, it was very controversial because people felt like they weren't going to get paid for their meaningful use incentives if they didn't have large portions of their population taking advantage of view, download, transmit. Lots of politics around that, and Medicare rolled back its rule and made it a lot easier to meet the meaningful use requirement. And in response, the patients got agitated. Meanwhile, back at the ranch at ONC, Congress had asked ONC to do a report on information blocking, and I'll get to that in just a minute. But one of the things we realized about information blocking was that organizations were making it way too hard for people to get their own data under this rule. And we flagged that for Congress in a report. So what do you get under this rule? Well, you get pretty much any information that's in a designated record set, and that is information that is used to make a decision about a person. So if you're in a health plan or a hospital system setting, that would be the records about their care, but it wouldn't be PHI you extract from that record and then send to your quality committee. Because that quality committee is making system-wide decisions, not individualized decisions. That's very clearly set up in these materials I've supplied. There's a certain time you have to give it within 30 days, but I'm going to tell you a story in just a second. And there's also a lot of rules about what you can charge. Let's just say you should charge as little as possible, and a state law that lets you charge more than federal law is preempted. Straight up. Because this is a right. It's a right to get your data. It's fundamental, and we can't have state law constraining fundamental individual rights. So we also thought that people would take advantage of this right of sharing and get that view, download, transmit by getting direct protocol addresses, but fast forward to 2017, and we realized that organizations who have direct protocol addresses have not told anyone what they are. How can you do a secure email to somebody else's direct protocol address if they don't tell you what the address is? It's sort of like saying, mail me something, but I won't tell you where I live. And we think that's because people were worried about security, and that's a good thing. But the whole point of the direct protocol address is your security protocols have been cleared ahead of time, and the packet arrives in a secure bundle. So you really actually shouldn't have to worry about it. You should maybe put your direct protocol address on your business card. And I did that. I went to my doctor and I said, I want to send you something. What's your direct protocol address? And they said, huh? All right. So ONC is still working on this, and the industry leaders are still working on this, and what we have now is application programming interfaces. So I'm assuming that most people in this room have a smartphone. Is that a fair assumption? And remotely as well. And probably at least half of you do online banking on your phone. And you're using an application programming interface for that, and it's got secure protocols to make sure that somebody isn't hacking your bank account, and we want to bring that to healthcare. Next slide, please. So after I left ONC, or right as I was leaving, I decided to do a little check or test of how easy it was to get my own data, and I tried 2 different methods. And I wrote an article about it for the Journal of AHIMA. That's a photograph from the article. That is the correspondence that was generated by me asking for the notes from my recent physical so I could get life insurance at Omada. That's a 2-inch stack of paper. And I'll tell you one story from the article, which it's not behind the paywall, so you can read it. So I needed the notes. And I messaged my physician on my app, and I said, why don't you copy and paste the notes into the portal, and I will just download them and send them to my life insurer. And she said, and I quote, HIPAA doesn't allow me to do that. Now, I didn't have the gold embossed business card anymore, so instead of arguing with her, which I would have done in a past life, I said, okay, why don't you print them, put them in a sealed brown envelope, leave them at the front desk, and I will come pick them up with my photo ID, which is the functional equivalent of 2-factor authentication to that portal. So we really have to move beyond this idea that there's something special and more secure about the paper system than there is by 2 factors of authentication that my organization issued to me when I presented myself in person. There wasn't even remote authentication here. Next slide, please. So I hope a lot of people in the room have seen Hidden Figures. And one of the untold stories of Hidden Figures, Layman's going, what is she talking about a movie about NASA for? Was it SpaceX yesterday? No. So one of the sort of subtle stories in Hidden Figures is, you remember, this is one of the computers. Remember, computers used to be people. And machines came to do the work of people. And that group of women, instead of running away afraid of those machines, became the experts on how to use those machines. And I love that story because I think that's what we need more of in healthcare, especially about electronic health information. Become an expert in how to make it happen instead of turning away and leaving it to the people who are too concerned to make this important healthcare-wide initiative happen. So I wanted you to imagine for a minute a few examples about how people want to get their own data and why we should make it easy for them. So one is caregiver access. So my mother was in Kaiser NorCal. She just passed this past year. About 4 years ago, they enabled me to have complete proxy access with my own account. I will tell you, true confessions, before then I would log in as her. I would call her and I'd say, I need to message your doctor. Can I log in? And she would say yes. And I would log in and I would say, dear Dr. and so, this is such and such person's daughter. And they all knew me. And I have this question I need you to answer. When they created a proxy account, it changed my life. Because first of all, I could separate my communications from my mother. And second of all, I could access all her labs, all of her test results. She had multiple chronic conditions, and really help her get a handle on them as she got older and older and went deeper and deeper into hospice. And this is not an uncommon need of people with profoundly ill children, profoundly ill parents that they're caring for, or profoundly ill spouses. Somebody who has managing any complicated health situation, even if it's a friend and not a blood relative, is going to need a bunch of information to help that person navigate their life. Another example, and I know you guys have a tertiary NICU up here in Solano County, right, at Davis. So you have people coming from all over, but eventually that child is going to get discharged and go home to a non-tertiary NICU, and that hospital is going to need to know everything about what happened to that baby when they were here. And if something happens at the home hospital and they have to come back to your tertiary facility, they need to have it come back. And we've got to figure out a way to do this so that we don't injure people and injure these severely ill children in particular as they go from remote places to a local centralized place. Lastly, MRI results. I had a friend who's a health IT lobbyist, and he had a knee problem, and he got an MRI, and we were having coffee, and he said, you know, the MRI center gave me my images on a CD. I don't even have a CD player. And I said, did you ask your physician to send you to an MRI center that would put it in the cloud and give you an account? So we have some agency here as consumers, if we want this to advance, to ask for it. Next slide, please. All right, we know sharing is required when an individual asks for it. Happy to answer questions about that at the end. You definitely should click on that link. It's a really great movie. I just don't have time to play all those materials today. So I really want to talk about when is sharing permitted. So I saw a few heads nod when I said that HIPAA has about 15 reasons why you can share without getting an individual's permission. And if you read your organization's notice of privacy practices, you probably tick them all off in that notice of privacy practice. But when a person presents themselves for coverage as a plan or as a patient, you probably also give them some kind of blanket authorization to sign, and your lawyers probably set that up to be, you know, redundantly protective of your organization. So this first paragraph is actually a list of the reasons why you can share PHI between two covered entities without an authorization. It's a pretty long list. When I was at ONC, we worked very closely with Office for Civil Rights on creating some fact sheets that were derived from this list and the actual examples that are currently in regulations, or that we could imagine from that we drew from other guidance that ONC did. Let me pause and remind you about what ONC does and what Office for Civil Rights does. So Office for Civil Rights actually enforces HIPAA. If you have a breach, you will report it to them and they will come and investigate. No questions about that. They actually write the HIPAA regulations, and when an organization in the government writes a regulation, a lot of other agencies have input. So the OCR 2013 regulations had a lot of input from CMS and a lot of input from ONC. ONC's magic power has historically been writing the rule for what the software did, which if you use that software as prescribed by Medicare, you would get paid. And that continues today in the MACRA and MIPS world, no matter what we think is happening with meaningful use. That is still the secret power of ONC. The Chief Privacy Officer's office at ONC is a little bit different. We, of course, advises on that rule and security standards, but also advises Congress and other agencies about how to implement health IT in their domains. And you're going to see some materials today that were created in that vein with SAMHSA. So we did a bunch of fact sheets. I'm going to review 4 for you today. One is, how do people exchange data for treatment, payment, and healthcare operations of their own? One is focused on treatment. One is focused on healthcare operations. And remember, it can be treatment needs you have as a provider, and it can be treatment needs another provider has. They are a co-equal legal entity. They're a covered entity. You're a covered entity. You have the same liabilities. Same with healthcare operations. I thought, given what you guys do here and the complexities in Northern California, it would be helpful to review a couple of others. So I have one for you on public health oversight, which in this world would be sort of the Department of Public Health, and then healthcare oversight, which is more DOI, DMHC, and DHCS. Next slide, please. All right. These are actual drawings that are on these fact sheets. We really tried to make this digestible by an ordinary person. They have been literacy checked for 8th grade literacy. But if you pull them down in PDF off the website, you would see the OCR government seal on them. They are 100% approved by OCR. You can definitely take them to your lawyers, to a negotiation, to your IT people, etc. So this example is pretty much what you might expect for treatment. We have patients at one hospital is going to go to a physician's office on discharge. We want to make sure that key health facts from the hospital get to the ambulatory setting so that post-discharge care can occur, that a readmission can be avoided, and hopefully the patient can continue to get better. Next slide, please. So this is a little bit more complicated. We all know that, particularly in California, where we have so many regulators who are so interested in quality and so interested in care coordination, we find ourselves in a lot of situations where an organization like Acme Medical Group down the road, and I'm making up names so I don't offend anybody, needs to hire a care coordinator and figure out what happened to its entire book of business patients. So in that drawing in the middle is the primary care physician's business associate. That's that organization that's going to collect the data. Now, the first thing I want to tell you is if I'm the doctor and I hire a business associate and they're going to come collect data from Lyman, he doesn't have to hire them as a business associate too. Not necessary. I have hired them. I have taken responsibility for them. I can ask Lyman for data. He can supply that data to me, and it's my responsibility to make sure my business associate doesn't run away with it. We use this every day at Omada. We report our results to get paid. If we had to do a business associate agreement with every analytics company our customers hire, and we have hundreds and hundreds of customers, I would be drowning in work, and I'd rather do other work. So in this example, the physician has hired this business associate to collect all this data and create a care plan. And then that care plan that's created from 6 different sources is going back to the PCP so they can implement it for the patient. Completely permissible under the care coordination rules of HIPAA. Next slide, please. I'm gonna grab my water. So this is another version of doctor to hospital. Only in this case, we have a patient, they're going to be discharged. They have some very specific needs, and the hospital needs to find the right rehab facility. There's 3 rehab facilities in this particular example. And in fact, you have to share PHI to figure out which is the right one. If you had a patient that had special language needs, you would want to make sure that rehab facility had assistants and providers that could supply that language. And you would have to start talking about the health condition of your patient. Again, 100% permitted under the sharing rules of HIPAA. Next slide, please. All right. Now we get a little tricky because we know that providers and payers don't always get along so well. And I can tell, I've been around a long time since HEDIS was a new thing, and it was called the Health Employer Data Information Set instead of Healthcare Effectiveness Data Information Set. This is an example of how payers and providers, who are both covered entities, I would add, can share data when the payer needs to do a healthcare operation for the people that that provider is treating. You can see that the drawing looks almost exactly the same. And I remember quite distinctly, I think it was 2008, a Cal PSAB meeting where we had this very long discussion about who was doing care coordination in California. And at that time, which was 10 years ago now, it was health plans. Now I think more and more provider organizations are undertaking that obligation themselves. But you have to imagine that this rule, which is 20 years old, allows both the payer and the provider to collect this PHI about a person they share in common to create a coordinated care plan. And if you think about where Medicare is going and the value-based purchasing that Medicare is heading towards, and Medicaid as well, it's all about coordinating the care amongst the providers based on the medical condition of that patient, meaning PHI. Next slide, please. All right. So an ACO, Accountable Care Organization. So we have a long history of integrated multi-specialty care through our HMO business in California. This may be really familiar to us, but in the rest of the world, this was a head scratcher for people. But clearly, if you're assessing quality And sharing of data for quality assessment is a specifically allowed sharing purpose under HIPAA. You can make this picture happen, which is 6 different sources of PHI, 3 different sources of PHI, 3 physicians' practices, whatever, are all feeding data up to the quality committee so that they can run the scores they need to manage the quality and improve the outcomes in that ACO's risk-based business. Next slide, please. All right, health information exchange, near and dear to Lyman's own heart. Again, I have battle scars from these pre-high-tech discussions in California, and I was doing a deal for United Healthcare and Cal Rio at the time high-tech passed. That's all history. You can go back and read the newspaper clippings. In any event, health information exchange, the government put $300 million directly into health information exchange, as well as writing software rules like direct protocol and other software rules that supported the idea of exchange, whether community-based or private, and required exchange in order to receive meaningful use dollars. And we'll talk about those attestations at the end. But this is a very simple example of an HIE. Clearly, one provider, the purpose of an HIE is for one provider to use this intermediary business associate to supply data to a different provider. And it could be within the same community or the same county, and it could be transnationally, like through Chic. And all of that is 100% allowed. In addition, that HIE could be contracted by all of its constituent providers to do quality analysis and quality improvement. Additionally, that HIE could, and we'll get to this in a minute, actually give the individuals their own data without the intervention of the outside physicians and hospitals. Next slide, please. All right, so sometimes it looks, we want to have a hospital, a community where there's multiple hospitals that might be competing from a legal affiliation standpoint, may actually want to address something that's across their entire community. So those of you who are old enough will remember the AIDS crisis in the 80s and 90s. Ebola was another example, and when this happened, if we had a big flu outbreak in Northern California, we might want to do this again, where people want to share the data so they can track the disease across the population and look at addressing it at a population level instead of on a person-by-person basis. Definitely tracking diseases and population health is a specific criteria in one of the permitted sharing rules, if you went back 6 slides ago, and we just drew an illustration for you. Next slide, please. Well, I'm exhausted, and that was just treatment, payment, and healthcare operations. I hope that gave you a lot of something to think about, and I definitely, the idea behind creating these public fact sheets that are not copyrighted is that you will use them over and over again. That is literally the idea. I was the brainchild behind this, but I did not draw these pictures, and they are not intellectually properly, they are not protected by copyright, so you should just feel free to use them. All right, next up, public health. We did this because of the Ebola crisis. Because during the Ebola crisis, when I worked in the administration, people had no idea what they could or could not share with their public health agencies, whether it was about individuals who in fact had been exposed to Ebola in West Africa, or about individuals, we had discrimination, who were being retained against their will because they had a West African passport, which is a whole other problem. But public health agencies have pretty broad powers to collect PHI about people who present health risks to the community, or where the information will help them manage the health of the entire community. And again, going back to the AIDS crisis, so many good lessons from that. An interesting little side note was, in fact, the public health agencies of California had really broad powers, but they were kind of abused because the data wasn't held. It's not that it wasn't collected, it was collected, it wasn't held secret, and then people's HIV status was disclosed, and then they were discriminated against. And that's the key thing, is they were discriminated against. Not that the state collected it, that was necessary. It was that they didn't keep it safe, and then the individuals were discriminated against. So you have to separate what we're trying to manage as if the government's trying to manage health overall versus what happens to private people. And that's what privacy is all about. What is happening to individuals? Don't let bad things happen to them because of their health status. Next slide, please. All right, last one. So California is probably the most heavily regulated health economy in the country, right? We have 3 state agencies that just oversee the delivery system, which doesn't even account for physician licensure and how we inspect hospitals and the county level. So Department of Managed Healthcare for HMOs and multi-specialty group practices that bear risk, Department of Insurance for health insurance, and Department of Healthcare Services on the Medicaid side. I think if you were just at an audit, they probably asked for some PHI, or there may have been a dialogue about that, and that's a pretty common thing. A state should be asking for PHI that it needs to investigate a particularized complaint or a pattern that is derived from a complaint, not just in general phishing for people and their information, but by the same token, they have broad powers to ask for that data. Licensure often hinges on the supply of that data. Having been at United Healthcare, I know a lot about that. And we should collaborate with our state regulators to make sure we have fundamental measures of quality and professionalism within our healthcare system. Next slide, please. All right, so that's a basic contour of HIPAA. Here's an observation though, right? HIPAA sets a minimum nationally, and under HIPAA and the regulations, people and organizations are required to set their own policies and practices. So it's not uncommon that those policies and practices are much more restrictive than HIPAA itself. So back to what happens when you go to the doctor's office, you get your notice of privacy practices, or like me, recently I got an FCC texting disclosure, but I didn't get my HIPAA NPP, and don't ever do that to me because you'll show up on Twitter. Absolutely. But you get your notice of privacy practice, and you're made to sign an authorization, and then you're made to sign another authorization if you ask for your data yourself. But those latter two authorizations are just unnecessary. An authorization is for when you're not allowed to share it under HIPAA without an authorization. 15 conditions why you can. There's a bunch why you can't, but most of healthcare is going to happen in those 15. So you have to think about when you're an organization that wants to facilitate health information exchange, facilitate patient engagement, get your roster of people with their portal credentials higher, you have to think about whether your policies and procedures are making it harder than it needs to be. Back to that, I can't put the notes in the portal, but I can put them in a brown envelope. That organization also had a policy which said people at the front desk answering portal messages aren't allowed to respond to requests for information. You have to call an office an hour away that closes at 4:30 every day, because that's their policy. Completely unnecessary. All right, so here's some examples of organizational policies. At ONC, we identified these when we were talking about information blocking, which can be a business practice, and it can be old policies and procedures that are really impeding the business practices you want to have, but you haven't cleared them out yet. So if this presentation does nothing but give you some resources to help clear out the deadwood in your policies and procedures, hallelujah. So one is you just refuse to take advantage of the permitted rules. A counterparty who comes to you and wants information about a physician wants information about a shared patient, you're not required to share with the physician. You are required to share with the patient. And you just say no. Now you're making the patient have to do it. So that's okay when you're, relatively healthy and it's me and you're doing it, you know the rules and you're making an experiment. But if you're, the parent of a child who's trying to get into a research study because they're going to die of some dread disease in 3 years, and you're managing all the tests and all the protocols of the research study, the last thing you want to do is have to step in where your physician could ask for it for you, because the physician knows what they need. My pictures from Twitter are full of pictures of people who've sent me their electronic health record, which is usually a red robe envelope with paper and CDs in it. So another is requiring individuals to opt in to sharing. So we have gotten a lot of dialogue about opt-in and opt-out, especially as it relates to health information exchange in California. So this is my personal opinion. I think they're functionally exactly the same, and I don't think we've done enough behavioral science to really understand what it means. So there are definitely organizations that have opt-in, and it's taken them a long time to get to enough data on an opt-in basis to make the data set worthwhile for the physicians. I won't name names. And there are other organizations that have chosen an opt-out, and we can look at the opt-out rates after notification and annual re-notification. They remain in the 7 to 2% range of people opting out. And I'll tell you something, which is the original HIPAA rules. If you go back and look at all the background and the proposed rules, they were designed to make most of healthcare run without the patient ever having to do anything, because you know what? the patient's sick. We don't want a sick patient having to reset their privacy policies when they're in an ambulance. We don't want to make the mother or father of a profoundly ill child or a very sick grown-up parent have to engage in all this process to make the information move. And survey after survey, ONC conducted them, Pew has conducted them, Robert Wood Johnson has conducted them, National Partnership for Women and Families have conducted them, have in the 70 to 80% range, people just expect their physicians to be exchanging this information already, because that's what's supposed to happen to make their lives easy. And if you're thinking about patient engagement and people taking active control of their health and managing their health like we do at Omada, we don't make money if we don't engage the patient. Boy, if we kept everything a secret and made it hard for them, we would have been out of business a long time ago. All right, so requiring paper after you already have secure credentials. Back to that portal story. I logged in with 2 credentials to that portal, and they had given me those credentials after in-person presentation with my driver's license and my insurance card. Like, really, it just doesn't get more secure than that. And if I share my credentials with someone, bad practice, but you can't stop me from doing that anyway. So why ask me to do more paper when I've already given you something secure? And that's something we do at Omada. When our patients call, our participants call and ask for their own data, I ask the call center, I'm like, how do you know it's them? Oh, we go through this whole protocol to assure it's them. I'm like, good, then don't give them any paper. Just prepare the data and securely email it to them. Let's move on. And then, of course, refusing to transmit to unaffiliated organizations. And yes, this still happens. So I love to tell stories. My husband fell down and fainted in our kitchen. This was 2011. High Tech had been in place for a few years. Went to a local ER, unaffiliated with his medical group, got some stitches, and that did not work for the government then, but I had told the story to Secretary Burwell, and I said, we asked for them to transmit the visit summary to my husband's medical group, unaffiliated, and they said, and I quote, HIPAA doesn't allow us to do that. It's, 8 o'clock at night in the ER, and you've got stitches in your head, you're not going to have an argument about it. But honestly, we went home, took a picture with the cell phone, emailed it to the doctor, and he said, great, come in 5 days, and I'll take the stitches out for you. So we provided him information overnight, but the hospital would have made us fill out paper, wait 30 days. The stitches would have been out by then. And I just heard an anecdote recently of an organization that did not want to contract with a community-based HIE because they felt like they got all the exchange they needed from the garden or the infrastructure supplied by their EHR vendor that they shared with most of their referral patterns. And, that's a business choice, but just think about that choice for a minute in terms of unaffiliated practices and what is really in the patient's best interest. Next slide. Watching my time. I'm almost out of time. All right, let me get to part 2. So I wanted to give you the quote from California Civil Code. It's a very long piece of code. You should definitely consult with your lawyers about it. But on the left is what it says, and on the right is the corollary HIPAA regulation, and you can look at it and read it. Information may, permissive, be disclosed to providers, healthcare service plans, that's HMOs, contractors or other healthcare professionals or facilities for purposes of diagnosis or treatment, and it includes emergency disclosures, medical transportation, etc. So in terms of disclosure for treatment, California Civil Code is 100% consistent with HIPAA, in my opinion. Next slide. All right, part 2. How many of you, just in the room, and we'll take it as a proportion, think that part 2 applies to something other than substance use disorder treatment? All right, you all get an A for the day. That's the first myth I usually have to disabuse. It only applies to federally funded substance use disorder programs. So what are those? Well, they're not private coverage because that's not federally funded substance use disorder coverage. Actually, it doesn't apply to emergency room treatment for an overdose, and I've given you some new OCR information about that at the bottom and at the end. Let me repeat that. An emergency room treating somebody for an opioid overdose is not a federally funded substance use disorder program because they're not in the regular business of providing substance use disorder services. It kind of makes sense, but it took us 4 years to get there. It doesn't apply to mental health and behavioral health disorders that are not substance abuse. Now, Lyman has heard this story probably 2 or 3 times, but my mother, back to my mother, she was bipolar her whole life. She was on lithium until about 3 years before she passed. She was never a substance use disorder patient, ever. Part 2 didn't apply to her care at all. whether it was paid by Medicare. If she'd been on Medi-Cal, it wouldn't have applied because she just had a mental health diagnosis and she took anti-anxiety medications and some lithium, but she wasn't getting substance use disorder services. So people rightly are very cautious around Part 2, particularly in these days of the opioid crisis. But again, it's just this extremely specific set of circumstances. The other thing I want to say about that is, of course, there's a new rule out right last January, and it's finally taken effect, and it actually has some liberalization, kind of as far as SAMHSA thought they could go in letting the patient decide to disclose not to each specific provider, which is the old rule, but in general to my treating providers, especially treating providers who are subscribed to a local HIE. So if that is of interest to you, you should definitely look up that rule. I've linked some resources for you, and I'll go over a few of them at a high level. And I'll try to connect Lyman. There should be somebody from Region 9 SAMHSA who would be able to come and talk to you about that. So here's the other thing about Part 2. There's actually a statute, right? The lawyers in the room will know that you don't get a regulation unless Congress tells you in a statute to write one. And that statute usually has some other rights and responsibilities in it. And Part 2 is derived from a statutory protection. So if you want to loosen Part 2, you're going to have to go to the root, which is the statute. Now, we've had a lot of conversations with Congress about this when I was at ONC. I've talked to many senators about it since then. Some of them are like, oh, you're right, there's a statute. We have some responsibility here as Congress to make sure the laws are right for the public health problem at hand. But you also have to remember, Part 2 and the statute derive from a similar crisis of heroin in the 70s. And what we want to avoid is people being discriminated against because they're addicts. And people refusing to go to treatment or refusing to seek out treatment because they think they'll be arrested and jailed instead of given treatment. And that is part of what this statute and this regulatory construct are designed to prevent. Give the power to the patient so that they control who gets the information so that they can prevent bad things from happening to themselves. And the providers and the patients in this space, they're not of one mind about what should happen here. If everyone was on board, they could get Congress to do it, but they are quite mixed in their approach. And that's important to remember, too, that this is all a political dialogue when we change a law. And it's on us as providers or patients or family members to bring issues to the fore so that they can get addressed. All right, the two links. These are extremely recent. The top one is issued in December. OCR has a whole FAQ about emergency departments and families of addicts who are suffering an overdose. Secondly, we also worked really hard at ONC with SAMHSA to develop a way to electronically tag the data that was flowing through the system as requiring special handling. Now, there's a lot of controversy about this standard, but it is HL7 approved. It's called DS4P, Data Segmentation for Privacy, and it allows you to put a metadata tag on a CCDA. I know I'm speaking Greek to some people, but the IT guys taking notes. So that when you disclose it, the recipient goes, oh, I have to specially handle this data. Or if you receive a tagged CCDA, you can say, oh, I need to specially handle it once I get it. So there's a great DS4P resource page that ONC has stood up with SAMHSA's help. SAMHSA paid for that development work, and in fact, it's an optional certification criteria for the 2015 rule. So if you are interested in that, you should go to your vendor and say, what do I have to do to put DS4P in my system so I can tag these CCDAs? And lastly, of course, prescription drug monitoring programs. I've given you the link to California's page. The Attorney General has a great page on this. You should all know what those are, but the idea is, right, identify the drug shoppers before they shop and refer them to treatment. Next slide, please. All right, mental health information. So back to my mom. My mom was quite the raging granny, and she has populated a lot of my work. May she rest in peace. But she was pretty angry that she couldn't get the information that she wanted the way she wanted it, and that I couldn't get it, and we had to go through all these conniptions. And that it kind of became my personal mission. So even in Congress, last year they passed 21st Century Cures. In the run-up to the passage of that law, we probably spent 9 months educating legislative staffers about what Part 2 applies to and what it doesn't apply to, and the fact that HIPAA does not specially regulate mental health information at all. Period. It's not in there. Psychiatric notes prison records. I went over that, but not in the physician's office. So if a physician prescribes an antidepressive drug or an anti-anxiety drug or marks a person as needing referral to behavioral services because they have depression, and I know there are all HEDIS scores on that, that stuff isn't specially protected by HIPAA, although it may be protected by various state laws. So Congress, in fact, directed, once we made this clear that it really wasn't a HIPAA problem, Congress, in fact, directed OCR to do a lot more work in educating people on what HIPAA does and what state law does. Congress cannot change state law unless they make HIPAA the preemptive law of the land. That is not going to happen anytime soon, as much as I wish it would. Made my life easy. And I would refer you to that, a section of 21st Century Cures, and look for that information from OCR. And that some of this is redundant. Emergency rooms are not providing substance use treatment services, et cetera. So I bet there's a lot of confusion about what California laws on mental health cover for HIE and what they don't. And I will tell you what the NGA concluded at the end of 2016. They did a further study on this. They studied this once before, and they did it again in 2016. And, top 5 takeaway for talking to 85 stakeholders in every public health department in the country was state attorney generals should help stakeholders understand what state law means and issue guidance about that you can take to the bank, and your lawyers will know exactly what to do with it. But until the attorney generals step in and help us interpret these laws, we'll keep being confused because party A's lawyer will think one thing and party B's lawyer will think another thing, and the government doesn't really have the authority to tell states what their laws mean. Next slide, please. All right, security. So I am not a security expert. I'm going to give you a few tips. I'm going to give some names to Lyman for future talks, and I'm happy to answer questions at the end. But a key thing about security is it's flexible, extensible, and scalable, and I'm quoting OCR when I say that, which means you have to figure out what's right for your organization through a security risk assessment. And a security risk assessment can be something you do for your entire organization once a year, periodically, or for particular transactions. And we do that at Omada. People say, can I do blah, blah, blah? And I'm like, if we do it this way, it has this risk. If we have to do it that way, it has that risk. Let's assess the risk and document it and make a legitimate business decision. So you should assess your risk regularly. There are resources at the back that ONC has created that help small practices do security risk assessments. It should not be something where it's one and done. It should also not be something where you assess your risk, find problems, and don't fix them. So it also has to be right. You have to think about security in terms of the right size. So we had a lot of dialogue at ONC about application programming interfaces and individuals, back to individuals' right of accessing their data. So if I'm using an app to go to an API, to read on the API, and all I can do is draw data down, and the disclosing organization already has the obligation to make sure there's a good patient match, like that's already true with data integrity, I don't present very much risk to the system unless there's some way that app could deposit a virus. But the drawing of data for myself, I'm a very low security vector. I can't write to the system. I can't get other people's data. If I could get other people's data, your credentialing system is not working right. You have a bigger problem. Versus system users, so people who are health professionals within a particular building or across the system who might have wide access to lots and lots of patients' records. And you can go back in the press and read stories about, receptionists who peeked in movie stars' data at Cedars-Sinai. That's a pretty famous case, or Octomom. They had wide system access and they misused it. So we can train our system users and we can monitor what they're doing, but also sometimes bad people do bad things and stupid people do bad things. And lastly, administrative privileges. So imagine that you're, one of the senior administrators at any one of the big marquee EHR vendors. You've not only got access to the records for all of Northern California, but maybe every Epic user in California or every Cerner user in California. So thousands and thousands and thousands of people. And each one of those has to have, has different risks that apply to it and different vectors. And of course, train your workforce, and retrain your workforce. Next slide, please. So here are some resources that I think will help you in security. So while I was at ONC, we finished a buying guide, which is for primarily small practices, how to buy EHRs, but has some great tips about negotiating security with your EHR vendor. It's also becoming, at least from my view and talking to security professionals, pretty clear that cloud is the way to go. We use all cloud at Amazon. They have an economy of scale with their background checks and their biometric controls and their redundant systems and their multiple locations that we could never hope to achieve on our own. And if you think about Hollywood Hospital, ransomware, they didn't have a redundant backup system and they had client-side servers. So just think about that as you plan your own system. And there's great guidance from OCR about cloud vendors who now know that they are business associates. You may or may not have the leverage to get good terms. We're a little teeny company at Omada. We just sign what our cloud vendor gives us. We can't negotiate that. We'd like to try. We aspire to. We have the knowledge and acumen to, but we don't have the bandwidth. There are some great training games on ONC's website, and there's the link to the security risk assessment tool. So back to cloud, I was actually at a policy thing, and somebody from a very large provider lobby said, well, the small doctor's practices, nobody knows what the threats are. And I said, that's not true. Homeland Security has a system where you can get credentialed to log in every single day, in fact, multiple times a day, and find out what the threats are that you should be paying attention to that day, which doesn't mean we expect a physician to do that, or even a nurse's assistant, or even the receptionist in that office. But we do expect that organization to take advantage of the fact that somebody else can do that, whether it's through the FBI, their security consultant, whoever. But in fact, we have a daily threat list, and that's a link to that. Obviously, background checks, cloud vendors can do that much better, redundant backup systems. And lastly, threat sharing, right? So the example I used to give is Neighborhood Watch. Who participates in a Neighborhood Watch? Next door neighborhood, whatever. And the idea is, hey, somebody's casing your place, or you left your window open, right? So that's what threat sharing is. Sharing with the community you participate in healthcare threats you become aware of. It's not sharing the PHI in your system with some other organization that's not entitled to it. It's, hey, I found this virus, and it turns out it came from this phishing email, and you should make sure your people don't click on this phishing email, because more than half of security is flawed human behavior. Next slide. Almost done. Yep, I got 5 minutes left. Okay, what's coming? Application programming interfaces. We've talked about this a little bit. So it's required to have an open specification API that's based on the Fast Health Information Resource Standard as of this past January to maintain your certification. And in fact, it's required to allow it to work in January of 2019. And that's a specific measure under MIPS. So the Advancing Care Information Measure requires that you allow a person's app of their own choosing to go fetch their data for them. There's a lot of resources about that. I have a bunch in the back. This is a little bit controversial for people, but again, we're trying to bring healthcare to where banking is now, because that's where people are. More than half of the people in the US have a smartphone of some kind, even if it's a reloadable. And that's where they're doing their computing. So just to drive the point home, an open specification API doesn't mean anyone can come and get the data. It means you publish the design so that an engineer can write an app that will interoperate with it. It doesn't mean you publish the data that's in the API. We just stood up an API for some business partners at Omada. It's a read-only API. We negotiated the specs. We set up the data bundle. We credential the users. It's all part of normal business for us. Next slide. All right, API. What's an API? Does anyone know besides the IT guys in the room? Just think of it as a secret doorbell. I've linked to the Joint API Task Force. This has a great explanation for lay people of what is an API in this particular context, but it's, if you have the pizza guy comes and he rings your doorbell the wrong way, you're not going to let him in. But if you know he's coming and you've given him the secret doorbell, the secret handshake, whatever you want to say, you're going to let him come deliver that pizza, collect the pizza, whatever you want. So there's a link to that, and you can go to the whole API task force is all available online. Next slide. So lastly, I want to talk about authentication, identity, and automation. So we seem to be really stuck with pen and paper, but since 2000, we've had the Federal e-Sign Act, which applies 100% in healthcare. OCR has been very clear that if you have an e-sign signed document, it's exactly the same as an ink signed document in healthcare. Other sectors use this widely. I've refinanced my mortgage with e-sign. Right. So we don't use it very much in healthcare, but we should use it more, particularly if we're credentialing our individuals and they're presenting the credentials we gave to them. So I've given you some resources here. There's actually a security challenge for that Fire-based API right now, because despite the fact that you're issuing credentials and a person can assign their credentials to their app using OAuth, I know I'm speaking Greek to half the room, people still are really worried about fraudulent apps presenting themselves, and they should be. But again, it has to be evaluated carefully. In addition, ONC just published just last week, they did a bunch of experiments for the precision medicine program on using APIs to move data out of EHRs and into the research space. And they did a white paper on the privacy and security findings about that, how it worked from a privacy and security setting. I'm really proud of that because I asked them to put the money on that contract, and I'm really glad that the information is out. All right, back to required sharing. Next slide. And this is the last one. So we have a lot of new technologies. We have optical character recognition that not only just reads the faxes, but actually starts interpreting them and applying natural language processing to them to give them a context. So Metal is an example of that, where they're taking thousands of pages of faxed and stored documents from fax service and turning it into structured data that can then be used by the institutions that use those services. Obviously, we've come a long way in patient matching algorithms, and it's a whole nother day to talk about the challenges of why we don't have a national patient identifier. And we have apps. This is what people are using. 140,000 people have used Omada. We have apps that can track how you're using your rescue inhaler with digital technology. That's Propeller Health. We have apps that warn you about pollen counts so that your asthmatics can stay inside that day. We have a new radio-enabled blood glucose monitor, right? You put a patch on, you swipe the Abbott thing over it, you don't prick yourself anymore, it's monitoring your blood glucose. Just approved by the FDA about a month ago. And we have nanotechnology-coated pills. So if you digest the pill, it sends a signal, tells your doctor you took the pill. No signal, you're not adherent, you get a call. Could you please take that pill? In that particular case, it's a pill for severely depressed people. Next slide. So automation is here. And fitness trackers, this is my last slide. How many of you have a Fitbit? I do not, but all right. Did you know that's not regulated by HIPAA at all? So there's a whole role here for the Federal Trade Commission with your trackers and the Stravas on your phone and, whatever you're collecting for yourself on the internet. I've given some resources about that in the back. And they're an important privacy regulator too, but they oversee a lot of sectors besides healthcare, and they also don't oversee nonprofits. So for you guys, not quite so much, but for the rest of the world and the world your patients live in, 100%. And lastly, those fitness trackers are generating patient-generated health data, so sometimes a doctor might actually want to see that data. We have to figure out how to get that data into the systems in a way that's structured, reliable, we know the provenance, it's not polluting the systems from a security perspective, and it's precise enough to be meaningful to the physician. So there's a new white paper about that, came out again last week by ONC. And there are some measures about that in MIPS. We could do a whole conversation about MIPS. I'd have to be somebody else. I'm a privacy person, not an incentives person, but there are definitely PGHD measures that allow you to get your MIPS incentives. All right, I can see I'm running over. Let's whip this. I think I'm on my last one. Next slide. Should be the last one. Yes. So 3/4 of American people have smartphones. That's what Pew says. White space is a problem. It's a problem where you guys do business. But it's less of a problem than it was 10 years ago. And it's going to become less and less of a problem, and we have to think about that. Omada, our solution is our scale is cellular, but it's 2G. And the engineers tell me it's never not worked, ever. We have people in Alaska. We have people in remote Northern California, and it's always worked. So Congress requires that we be able to exchange data without special effort, meaning if they are asking for data using a credential you gave them, why make them sign another piece of paper? That's what the app is. The app is without special effort, because that's how you get your banking right now. How many of you remember going to the bank to get money on Friday afternoon before the invention of ATMs? I sure do. That was a special effort. You had to organize your life to go out for the weekend. Okay, we're beyond that now. That was 40 years ago. Lastly, I wanted to call your attention to an important deadline. So, ONC has a new framework out on trust and governance and data sharing. The deadline for comment is February 20th. I've given you the link to their draft. I don't know if you're commenting. There's no requirement that you sign. ONC can't do that, but it does condition your behavior if you do sign on. And a question we have to ask ourselves is, will this framework plus the incentives and maps in MIPS and MACRA start changing behavior at an accelerated pace? I don't know the answer to that question. Lastly, back to the HIE, 21st Century Cures gives business associates the ability to choose to disclose patient data to them without you asking them to. Old world, they could only disclose it if you were delegated that responsibility from a covered entity. New world, the business associate can choose that as a business model for whatever reason. They can't charge more than you can be charged, but maybe they want to just do it for patient engagement. Maybe they want to do it to value add. Maybe it's a completely hollow ability and nobody will take them up. All right, I think that is the end. I've said enough. Can I go a little longer for questions? All right. Next slide, which I think you guys have seen, the Tesla Model T slide. Who would not want to drive a Tesla today? We don't stop driving just because there are other idiots and bad drivers on the road. And we shouldn't not exchange just because they're bad people, because we can track that and monitor it. And we should not exchange just because other people don't. We should be smart about it, and we should be on the vanguard of that health information highway. By the way, nobody can sue you personally under HIPAA. There's no private right of action. So think about that when you think about liability. And lastly, someday, before I die, it will be a medical standard of practice to exchange. And it will be not standard to not exchange. And in fact, the first lawsuit's been brought against eClinicalWorks for malpractice. Who knows what will come of that? But the allegation is they refused to make the data available and somebody was physically harmed. All right. The next slide should definitely be the questions and the end. There we go. My favorite use cases. I'm going to turn it over to questions.
Why don't we, to be fair, why don't we start with the remote sites?
However you want to manage it.
Can you hook us to each remote site? And we can ask for questions there. But keep the recording on, please. There's a remote site. We have questions from Santa Rosa.
Hi, yes. This is Teresa Tillman, Redwood Community Health Coalition. Thank you very much. I just have a question. If you could comment to your slide relative to 42 CFR Part 2, how that relates to federally qualified health centers who are now doing medication-assisted treatment and drug Medi-Cal expansion. How is Part 2 applicable to them, and in which kind of instances?
The best thing I can suggest that you do is I'll try to work with Lyman to find a Region 9, HHS Region 9 SAMHSA person to come. This is my generalized understanding. I'm not an expert in Part 2, and I did not work in SAMHSA, so just that's the caveat. What I understand is that you're no different than other organizations that have always had a medical side and a substance abuse disorder side, and the important thing is to treat them as kind of a unit within a unit, so that you're imposing your information controls on the substance abuse treatment program activity and not on your medical activity. So that's one method. And the second is the new regulation actually has some examples about proportionality. So looking at your total book of business and what is the kind of service you provide and when do you sort of cross the line that for particular patients it's substance use disorder treatment. So I definitely go to the preamble of the new regulation and look up that in the example. So you pull that down with your Adobe Reader and you search for the right words and then you read, or have your lawyer read it. But that's the expensive way. Any other questions from Santa Rosa?
Hi, yes, Dave Rothery from Marin County. You mentioned that under the 42 CFR Part 2, that emergency departments aren't covered. Well, they don't come under 42 CFR Part 2 with regards to the substance use information. But if they get that information from a program, they're now a legal holder, and therefore they are covered with that information, correct?
Yeah, the FAQ from OCR is about what the emergency department can tell other people when they've treated the overdosed patient. But data disclosed under 42 CFR Part 2 continues to have that characteristic. And that's why that tagging technology is so important. So that if your emergency department got a CCDA from a substance use disorder program, you would know that you had to continue to treat it according to the rule. And that hasn't been alleviated because, again, there's a statute and it defines the nature of the problem in totality. There are a lot of people were disappointed that that rule did not go as far as they wanted it to, but SAMHSA's pretty adamant that they took it as far as they thought they could get away with. Given all these other countervailing things, the patients don't all agree, a lot of disagreement amongst the community and statutory constraints. Did that answer your question?
Yes, thanks.
Okay. Any other questions from Santa Rosa? All right, Reading.
We're taking it all in.
You look like you're all asleep. I tried to be funny. I hope I succeeded. All right. Well, that's fine if you don't have questions. I'm sure that Lyman will come to me and say they have more questions. And we'll figure out how to get them answered. Anyone in Patrick's room?
That's Eureka.
That's Eureka. I've been abandoned.
Yeah, we had 5 there, and one of them I know couldn't make it.
Okay.
Sent me a note. Eureka's kind of a smaller place.
All right. Okay, we'll take it here in Fairfield. Yes.
I might have to repeat the question. I'm not sure how well the speakers will pick it up. But what if a patient discloses, let's say they show up in a health center and they disclose, I'm being seen at the narcotic treatment program down the way. And so they're verbally telling you, and you're putting it in your medical record. Is that medical record radioactive because you've put this piece of information in, or because they've disclosed, and mostly concerned about the redisclosure when somebody requests that medical record. But it is part of that history that you've taken that day. The patient has told you this information, and it pertains to the patient's care that day.
So based on those facts, my opinion would be no, because you're not a federally funded substance use treatment program. You're just collecting the information in the ER in a normal course. There's actually, in the materials I supplied, there's actually a new infographic about almost that exact setup. And not only that, patients can tell you whatever the hell they want. We don't regulate private people. They can tell you or not tell you. And so the latter is kind of more of the problem unless the former is a lie. But the patient can tell you that they've been in a program and they can say, please go get my data. What do I have to sign for you to get that? Because patients who are actually in recovery, again, SAMHSA surveys pretty much know that if their providers don't know they're taking something as part of a substance use disorder program, they could get the wrong prescription and have a really bad medical event up to and including death or, brain death. So that's how I would answer that question, but you should definitely take that material and consult with whoever's giving you advice, because I don't want to, I got my own, can't undermine the other lawyer's thing. Other questions in the room? Yes.
I'm an HIE, and I'm kind of naive in this and not fully understanding, but we're looking at the HIE, and we have a federally qualified health center, and then we have behavioral health, which falls under mental health, California regulations, and also substance abuse, 42 CFR. And we're looking at our HIE right now and trying to pull together our app. So we're still in the beginning stages of trying to sort this all out. So we have 2 different EHRs because of the type of business that we do. I guess the question comes down to the opt-in and opt-out. So they can opt in to have their medical information, their primary care, FQHC, all of that, dental records, whatever. But they want to opt out from having their substance use records.
So a lawyer should look at your total situation, and I would take you back to the tagging technology. Again, it's one of those things where if people don't demand it, it'll never take root, but it's there. And you could tag the records from your behavioral program and tag the records from your substance use disorder program for special handling, and the computer should be able to keep them segregated because of the tag. So your engineers should be able to figure that out. But the 42 CFR Part 2 rules and the state rules give a person a right to, it's not really an opt-in, they give a person a right to control when disclosure occurs. And the new part of the 42 of the Part 2 rules makes the question you ask, can I disclose this, gives you the ability to broaden the disclosure that they're saying yes to, as opposed to opting in and opting out. That's not really the right way to think about it. In contrast, medical side, if it's treatment and it's just straight up medical and these other rules don't apply, you can see what part of the civil code applies. And HIPAA has a corollary rule for treatment. Opt in and opt out isn't necessarily required. We don't have a statutory right in California to say, thou shalt not exchange my medical information. In fact, you can tick off in your head integrated multi-specialty practice organizations where you can't get treated unless they can exchange your information. And you have a couple of facilities of them right here in Fairfield. And it's been that way their entire existence. So those organizations have a standard of care saying, I need to be able to exchange to treat you. You're not allowed to say, no, you can't exchange.
Then I have one other question. Many of the counties are involved in the whole person care concept. And I think there's a lot of confusion around that because, or I will say I'm confused around that.
You're not the only one, it's okay.
Because I look at all the players at the table and I'm looking at it from a healthcare provider and these are the rules and regulations I have to play by. But then housing wants information shared.
And you want information from housing.
Education wants information shared. And so there's this whole group of folks.
Yes.
But I can't get.
Are you here in Solano?
Getting past, yes.
So Alameda County did this interesting experiment. You can get DHCS to come tell you about it because Dr. Scott sponsored it, where they literally spent 3 years having all the social services agencies contract with each other for data sharing. Now that is painstakingly horrible work. Like no lawyer wants to do that, but we get it, right? Each of those agencies is got its own set of information rules that might derive from state law or federal law. For example, education, Federal Education Records Protection Act, right? So every agency has to figure out what it needs to do with its rules. And I actually think this is kind of the last frontier of HIE is how do you actually take advantage of social determinants of health as a concept when we've created a system where all the data on purpose is stuck inside its own particular rule set.
Absolutely.
And I've had this conversation with Dr. DeSalvo. This is a huge challenge, but nobody's really funding the work on the data liquidity, the data fluidity, whether it should be some kind of universal form. We might be able to alleviate that if we actually took advantage of e-sign. For example, you go to your local housing authority and they give you a tablet and you are there in person and you e-sign to let your housing data go to your doctor or vice versa. But we all know what the tech is like at county health agencies and county public social services agencies. They barely have an iPad, for the director, let alone one that can go out in the field. So we have a lot of challenges in this space, and the more impoverished the county is, the harder the challenges are. I don't have a good answer for you, but it's a huge problem.
Thank you.
Other questions in the room?
Okay.
Well, I think we should call it a day. I'll stay a few more minutes if there are private.
Could I ask one more question? Sorry, this is Santa Rosa, Teresa. So to your point about interoperability, understanding amongst organizations and counties and states, would the federal government ever venture to provide guidance on that?
The federal government will probably never provide guidance on what state laws and local ordinances mean, ever. They just don't have the power. They don't have the authority. We live in a federalized government, so each state has its own authorities, and those typically are on health and public health, and the federal government doesn't get too involved in that. And remember, HIPAA fundamentally is the minimum. It has to comply with HIPAA if nothing else, and it can be more privacy protected than that, and that's just the health realm. So I don't think that will happen anytime soon. I think it's more likely that the federal government would give advice on what technology localities and states can adopt that would facilitate interoperability. That's something they might do, and they've done a lot of that work with the NGA. But I'll tell you a little story. So this is Miami-Dade County. Actually, the people who sell the nanotech pill, Otsuka, funded this study. The county jail was severely overcrowded, and it turns out that more than 40% of the jail residents actually needed drug abuse programs and not jail. And so they were trying to figure out how to make all the information move so that when an offender presented in court and they needed treatment, not jail, the judge would have medical information to make the referral to a treatment bed, they actually had to go to the county board of supervisors and get a special ordinance passed that enabled this data to flow from the jail system to the judge to the treater. Now, it worked. Like, they emptied their jail and filled their treatment beds, and I don't know what the recidivism rate is on the treatment beds, but they accomplished their goal of getting people out of expensive beds that don't provide treatment into cheaper beds that do provide treatment. But they had to pass a law at the local level to let the county health department coordinate all this data moving around. Yes.
One more question. Could you speak to providers texting with their consumers or their patients from?
There are a number of really good, secure texting tools. You just have to buy them. And of course, patients can text their provider. Patients can disclose anything they want in any medium they want, secure or insecure. So there are a number of good tools out there that we have instant messaging within Omada that allows us to go back and forth with individuals securely. You just have to buy those tools. And they have to meet whatever your organizational security policies are. Mm-hmm. Anything else? All right, you guys, go change the world. Make everyone healthy.
For those of you that are in the remote sites, we'd like to start having a discussion about what other speakers we should have in this program. We're thinking about having one every 3 or 4 months, every 4 months, maybe the next one in May. Dr. Moore is going to lead that, and I'm going to put things on a couple of flip charts here, and we'll try to make some decisions with your input. So hopefully you can stay for that. Right. If you don't, we'll take your name and it'll be back.
Good, yeah. So we'll pause in case folks need to leave, but then those who want to give us some suggestions for future topics, and then after we're done with that, we'll be done, but we just want to take a moment to do that. So we'll maybe give a couple minutes in case people need to leave, and then we'll launch that question and answer. Go ahead. Yes.
Procedural question now.
Sure.
When I touch these links, they don't get anywhere.
Oh, yeah.
How can we access this electronically?
Lyman, are we going to be sending out a PowerPoint so they can access the links?
We'll send out the PowerPoints, and we'll send out, I'm not sure, is this going to be Jay, is this going to be
I think we have the PowerPoint. We have the PowerPoint.
Is this going to be the recording going to be like a web? No, will it be like a webinar, or will it be the audio only?
Audio and video.
Audio and video. So we'll find a place to post the recording, and we'll also send you the PowerPoint.
So that's a good question, though, because we might want to, this part we probably don't need recorded. Should we cut the recording, just have it be because people watching it afterwards.
Okay.
Yeah.
Well, I wasn't thinking for them, I was thinking for us, but that's fine. You can stop
We'll take
the
good notes.
recording.
Yeah.
Thank you.
Right. So the thought is to think about the different types of topics